All right, so we are going to talk about quality improvement today. I may turn that down just a little. And we're going to talk about why it's important to you, and why it's important to your patients. I have nothing to disclose. And just some of the things we're going to talk about, basic understanding about quality improvement, be able to distinguish the difference between quality improvement and quality assurance. We're going to talk about understanding that QI is really part of scientific method. Recognize that QI requires looking at data, processes, or trends over time, and we're going to look at the PDSA model, which has a number of different titles, and we'll talk about that. All right, so I'll read a couple of different comics. Usually there's about 4 that I seem to identify with, and this is one of them, Dilbert. I don't think my motivational messages are getting through to the employees, residents, faculty. I can't seem to make them pay attention to anything. Have you tried not being boring? Good idea. I'll make 50 slides of pure excitement. So I decided to double that and make 100. So no, we're not going to be that bad. But so what is QI? Quality improvement is using formal and systematic approach to continuous improvement. And so in the pediatric setting, we're ultimately focused on improving patient care. So QI activities aim at measuring and analyzing current processes and then figuring out ways to make them better. So why should you be interested in QI? So one is that as part of the 6 competencies and part of program requirements, ACGME requires it. So of the 6 competencies, practice-based learning and improvement is QI is included in that, as well as systems-based practice. So from our pediatric program requirements, residents are expected to develop skills and habits to be able to meet the following goals: systematically analyze practice using quality improvement methods, and implement changes with the goal of practice improvement. So we're going to talk about some quality improvement methods. Systems-based practice, it says that residents need to work in interprofessional teams to enhance patient safety and participate in identifying system errors and implementing potential system solutions. So patient safety and quality improvement are part of the same thing, but they're also different. As far as interprofessional teams, anybody have any idea what interprofessional teams are?
They are working in the same. So like
Different people that you work in.
As the child life people.
Exactly. So attendings. So it's what we do every day. So it's attendings, nurses, fellows, residents, students. So as far as QI is concerned, involving everybody is one of the things that's important. We'll talk about that. So ACGME requires it. The American Board of Pediatrics requires it. So whenever you finish and you become board certified, unless you have a lifetime certificate, which they are not giving out anymore, you have to participate in maintenance of certification. And so these are the 4 parts of maintenance of certification. I got a green pointer for St. Patrick's Day. Professional standing. So professional standing is just your being licensed in your state. Lifelong learning. So that's prep questions, CME. You have to do a certain amount for your maintenance of certification. Cognitive expertise. You have to take another test every 10 years now once you've become board certified in pediatrics. And then performance in practice. And so performance in practice is the part 4, and it says that it requires pediatricians to demonstrate competence in systematic measurement and improvement in patient care in work that's done in a variety of areas that is intended to improve child health. And so as part of this, you have to do a QI project. So everyone who's board certified who is participating in maintenance of certification has to do a QI project. So some of the other things, if you become a faculty member, you can actually use it for promotion and tenure. You can use you can have publications in QI. You can there's specific journals for QI. There are poster abstract presentations. If you are part of published practice guidelines, then that's all part of your promotion and tenure, as well as a resident, as a student. You can submit posters, abstracts for QI. So maintenance of certification, a lot of it, we just feel like it's busy work, and there's been a lot of pushback from a lot of different, the different subspecialties as far as all the different things that you have to do for maintenance of certification. But I do think that quality improvement is something that is important, and if there really is a way to help your patients, then it's something that we need to be interested in and be involved in. So some of the benefits of QI. So what are some of the benefits are that you can improve patient outcomes, you can improve your clinical practice, increase patient and family satisfaction, unite your healthcare team in a common goal, that's that interprofessional teams, improve efficiency and organizational effectiveness, and decrease costs. Okay? And so all of those are things that you're going to want to do whenever you're out in practice, whether that be in academic setting or in private practice. So quality assurance versus quality improvement. So this is the March conference schedule, and on the 4th, Dr. Keel does a great job with our QA M&M conference, but quality assurance and quality improvement aren't exactly the same thing. So QA is a program to maintain a certain level of quality of service. So maintenance is the key word for quality assurance. Quality improvement is known as performance improvement. So it's making small changes to increase the quality and to hopefully do this continuously. So QI is more dynamic. And so I'm going to draw a couple of graphs. It won't be quite like this. But so if you're looking at quality assurance, and say this is number of physicians, and then over here you've got whatever you're measuring, and this is better, and this is worse. And so quality assurance deals with benchmarks. Okay, so let's say a hospital is looking at wound infections, okay, and they want to keep post-op wound infections at less than 3%, okay, and so this is our benchmark, and so this is 3%. So if you have two hospitals, and say hospital A, their post-op wound infection rate is 2.8, okay? And then you have hospital B, and their post-op wound infection rate is 0.5%, okay? So you want to stay out of here, okay? This is bad, all right? This hospital is at 2.8, okay? So they are meeting the benchmark, they're staying within the smiley face, okay? But if you were having your knee replaced, which hospital would you rather have your knee replaced? Would you rather have it at B or would you rather have it at A? All right, you'd rather have it at A. So hospital A is maintaining the benchmark. They are meeting their quality assurance, okay? But what quality improvement does, and if you look at what the graphs really are for these, so if this is this hospital's average, that's what theirs really looks like. And so, and this one for Hospital A is really looking like this. So you've really got more that are in this bad part. And so what quality assurance does, or what quality improvement does, it tries to take this and it tries to shift it in the right direction. So you're trying to move everything over to the better. And so that's what QI is. Okay? Does that make sense? All right. So R. Edwards Deming was an electrical engineer, and then went and got his master's and then his PhD in mathematics and physics. And both of those were from Yale. So pretty bright guy. And he worked with industry, and he is who many credit as the, so many in Japan credit Deming as the inspiration for what became known as the Japanese post-war economic miracle. Japanese industry was devastated, and then, they moved up 50s, 60s, 70s, and became this small island nation became a world economic leader. And so what Deming did was he looked at a number of different things. He looked at Walter Shewhart, who's the father of quality control, and he developed, so Shewhart and Deming both developed the plan, do, check, act method. And so this has been converted to the Plan, Do, Study Act, PDSA. PDSA cycles are actually based on Francis Bacon's scientific method. So hypothesis, experiment, and then evaluation. And so the secret is that you need to repeat the cycle again. So it's continuous improvement is what you're aimed at. And so it's not just to do better and then stop, but it's to continually improve. So then Langley and Moen wrote a book in 2009, The Improvement Guide, A Practical Approach to Enhance Organizational Performance. And so they had a lot of healthcare things in here as well. And so this is the model of improvement that most people use and that we'll use. And so it's aim, measures, changes, and then the plan, do, study, act. So tools and methods that we're going to use. So aim. So what are we trying to accomplish? Okay, so you have to pick something. It needs to be something to where you're making incremental changes, and it doesn't have to be something big. And probably the smaller it is and the more manageable it is, the more likely that you're going to be able to really look at it, study it, and affect a change. So measures. How will we know that a change has been successful? So measurement of the effects of these changes over time. And so then there's three types of measures that we have to be concerned with. So process measures, outcome measures, and balancing measures. So the process measures quantify compliance with the practices that are being implemented. Okay? So you think about a change, and then you think about what you're going to do to help implement that change. Outcome measures gauge the impact of the initiative on the patient population. So let's say the aim is to improve asthma care for your patients. Okay? The goal is to reduce the frequency of severe asthma exacerbations. All right? So that's a worthy goal. So clinicians plan to achieve the goal by providing detailed asthma action plans for your patients. Okay? So the goal is to have every asthma patient have an action plan. So as far as the measures are concerned, the process measure may be to look at the percentage of patients who have an action plan documented. And so then the numerator is the number of patients with a documented action plan. The numerator is the number of patients with asthma that are in your practice. Okay, so that gives you the percentage. So So process measures, so your plan is to make sure they have an action plan. And so you can look and see, process, how many have an action plan. The outcome measure might be, so outcome measure deals with the impact of having an action plan on your patient population. So that may be decreased hospital admissions, decreased trips to the ER. Okay, so the outcome measures deal with the population. The process measure deals with what you decided to do as far as your action, your plan. Okay, so your process, the plan that you have, may or may not work. Okay, and so you may decide to do something. Say you were in a certain population and you gave an action plan to every single patient with asthma. You developed it. Let's say they were all Spanish speaking and they couldn't speak English. Okay, you would be 100% on your process, but your outcomes wouldn't have changed. Okay, and so then the other thing, and so sometimes measuring the outcomes is not possible, so you just track the process measures. And if they're based on a reasonable approach, if you're looking at practice guidelines, things that have been proven to work, then you can reasonably expect that your process measures are going to be successful. So it's, for us, we've got EPIC, but especially pre-EPIC days, it would have been really difficult for us to figure out how many of our patients had asthma, if we were making any change in their admission rates and that kind of thing. Now, the other measure is balancing measures, and so these are variables that can be used to assess potential negative consequences of a process change. All right, so everything that you do may not be positive. If you had, like say you were trying to decrease the number of asthma readmissions, okay? So if you were doing that, some of the things that may increase are length of stay, which costs more money and that kind of thing. So one of the negatives may be, even though you're doing what you had planned to do, and that's decrease readmissions, one of the negatives may be that they're staying in the hospital longer. Okay, and so that's what the balancing measures are. So changes, what change can we make that will result in an improvement? And so we'll look at that, and then the Plan, Do, Study, Act. So the Plan, Do, Study, Act cycle, so we're looking at, so everything that you do needs to be specific. So who we're trying to, what patient population, what patients we're looking at, what are we trying to do, where are we going to do it, and when are we going to try to make these changes. The do part, tests of change begin. So you decide what your plan is. The team documents any obstacles that are encountered so that they can be addressed, and then you begin the data analysis. Study, analyze the process and outcome data, record and summarize the lessons learned. And then act. So then you either need to decide if you're going to adopt what you're going to do, so it's worked, adapt it. So in the case with the action plan, if they were all Spanish speaking, then you need to, it's probably a good plan, but you need to adapt it to have your action plans in Spanish. Abandoning, this didn't work at all, we need to try something else. All right? And then you integrate the findings into the next PDSA cycle. So run charts provide an easy, practical way of tracking and displaying the data generated from a QI initiative. Okay, so whatever your outcome measure that you're trying to measure, process change 1, see if things got better or worse. Process change 2, process change 3. And so it's a continual. And so for maintenance certification for American Academy of Pediatrics and for American Board of Pediatrics. They usually require 2 different interventions for your plan. All right, some other tools. Lean and Six Sigma are 2 of them. Anybody know who this guy is? Jack Donaghy from 30 Rock. All right. And so Six Sigma is, I'm reading some of this stuff, and I remember Six Sigma from 30 Rock. All right. So, we're throwing out a lot of stuff. There's, all these acronyms, and it does seem like that sometimes it makes it intentionally confusing, consuming lunch and simple socializing. But Lean and Six Sigma are business models that are used. And in looking at things, I've actually seen some prep questions dealing with the next couple of things that I'm going to talk about. So Lean methodology focuses on reducing waste and improving workflow. And then Six Sigma is actually not 6 dudes. It's striving to decrease variation through detailed data collection and analysis. So basically, you're just trying to do the same thing the same way without variation. So we do this a lot of times with, practice guidelines, or the flow sheet that we use for neonates with fever. Part of that could be part of Six Sigma, okay? Because you're trying to decrease variation. You're using things that have worked for, that have been studied and that have been validated. And then commonly they put these 2 things together as a methodology, just known as Lean Six Sigma. Root cause analysis. A number of y'all have probably heard about this, but this is using a retrospective tool. So an adverse event has taken place, and then you look back to see if improvements can be made to prevent the reoccurrence. All right. So sometimes things just happen. Sometimes it's a system problem. So you identify system-based flaws and develop a systems-based solution. All right. And then FMEA, failure modes and effect analysis. All right, so the thing that you need to remember about this is that it's prospective. All right. So you're looking at methods to anticipate vulnerabilities or problems. All right. So root cause analysis is retrospective, and then FMEA is prospective. Okay. So I've seen one prep question on that, maybe on the boards, and so that's basically what you need to remember about it. Evidence-based medicine can be viewed as a QI strategy. And so whenever you implement evidence-based guidelines, use best practice guidelines, that's really a QI strategy. All right. And so everybody have that, everybody get a copy of the QI worksheet. And so you can use QI for lots of different things. And so for this one, you're identifying something that you could improve in your life. All right. And I thought about, why don't, I think we probably got enough time. So for this example, so what I want y'all to work on is, so example, I need to exercise more. So let's look at that, and let's see about going through the worksheet with that one. All right. So we've identified the area of your life that you think that could use improvement. So specific aim. So how good and by when. All right. So you need to figure out how much you're going to exercise and by when. So when do you want to make it to that level? And then think about changes that you can make to achieve the improvement. All right. So if you're not exercising as much as you'd like, think about some reasons why you're not, or some things that you can change to achieve your goal. And so then we'll talk about some of the outcome measures, process measures, and balance measures. Okay, so if y'all do the first three, and doesn't have to be detailed, just. All right, y'all got some things written down?
I think the goal should be like more food, 4 more months.
Okay, guys. So Wednesday continuity. So what are some some specific aims? How good and by when?
30 minutes a day.
You okay?
By when?
I like it.
That was this past weekend, right? It was 87 degrees.
Yeah. Already 80. All right. Monday.
We said 3 days a week by June.
Okay.
Right. And the reason we said June is because we were going to do 1 day a week for a month, and then 2 days a week for a month, and then work up to 3 days a week.
Great.
So that would be June.
Friday.
Well, see, we're kind of confused, so we made up our own. We made up our own day. I know we're going to exercise, I don't need to exercise anymore.
You okay?
She's a hip hop star.
Okay. See, and you can use QI for lots of areas of your life. So how good by when? So we talked about so 30 minutes 3 times weekly by May. So that seems like about what people think is reasonable. So some specific changes that can be made to help you improve, to help you achieve. Okay. Great. All right. We'll wake up early.
Either join the gym downstairs, which is $10 a month, and it comes out of your paycheck, so you probably won't miss it. Or put your clothes in the car and make sure you go to the gym before you ever go home.
Okay.
Cheap one is go up and down the stairs 6 floors.
So one of the examples, I'll wake up 45 minutes early on Monday, Wednesdays, and Fridays and exercise in the morning. All right? So how do you know if there's an improvement? So what are your measures? All right. So we've got outcome measures. So what are the outcome measures? So the outcome measure is how many times. So your plan was to exercise more. Your outcome measure is how many times you're going to exercise per week. Okay, so it's actually how many times you're doing what you said you were going to do. All right, so the process measure. So how many days you're waking up early. All right. So the process was that you were going to wake up early. The outcome is that you were going to exercise more. So what are some balance measures? So what may be some negatives? Okay. Kids late for school. Injury. Weather. If you're waking up early.
Tired.
All right. All right, so we looked at it. So aim measures changes we talked about. So task, you can set your alarm clock early. Plan for data collection. You can have a poster, you can have a notebook. Prediction, meet the goal 75% of the time. Do the test. So you woke up early, low on energy, to run before coffee, often sleepy at work. Study. So you met 75% of weeks as predicted, but change works, but tired at work. Low quality of run due to poor energy. Okay. And no coffee at work. So act, accept, modify, reject change. So remember, you either adopt it, you adjust it, or you abandon it. And so, so you look and see what seemed to work and what you can change. And then you do another cycle. So you make another change and do the cycle. Okay? So going forward, as far as a team approach, so one of the acronyms, besides Legos and lunch, is Sierra. So simple initiatives. So the key is to make it simple, stupid. Try to do it. Try to define something easy, manageable, that you're going to be able to test, that you're going to be able to do. So don't bite off more than you can chew. Interdisciplinary teams, we talked about that. The more people you can involve, the more the change will take effect. Early adopters, so you don't want to necessarily choose someone for your team that you know is always negative, is not going to be helpful in you achieving your goal. So rapid pilots, so these don't need to be long, drawn out things. They can be short, a few weeks. Look at what you're doing, analyze the data, make the changes, apply, adjust, or abandon. Rapid feedback. You're working as a team, so let the team know how the results are going. And then whenever when you've made appropriate gains, advertise it. Talk about what's worked. Talk about, we found that, just from hand washing that, nosocomial infections have decreased by, this amount. And so why is the team approach to QI important? So change will not occur unless there's a shared understanding of the need for change. And so what the team adds is more knowledge. So the more people you have, the better you're going to be able to, the more input you have, the better things are going to be. Better understanding of existing problems, added synergy for creative problem solving, and just a shared commitment and buy-in. You know that if you're part of something, then you tend to be more active in it. You tend to be more concerned about whether it's working or not. And so we're going to use continuity for our QI projects. Needs to be a team leader. We've decided on our teams, develop team guidelines, cultivate a culture for QI. So in Cincinnati, they are huge on QI. They use QI for everything. They've got a whole department just dedicated to QI. We went to, this summer in July, we all went to Bomet, Kenya to work at Tenwek. And it's a 300-bed hospital. They've got residents. There are a number of attendings who are U.S. and Kenyan trained. So this is labor and delivery. NICU is in the back. That's Danielle. This guy named Larry Keft who's going to be here. But there's this poster on the board here. And so this was one of their quality improvement plans that they did. And so they looked at birth asphyxia and delivery room death. And so there's an international program helping babies breathe training. And so they did. So they looked at birth asphyxia, they looked at delivery room deaths. They revised. So the things weren't perfect, so they revised when to call peds. And so you can see that, even in developing countries, they're using QI. And then they had everybody sign everybody who participated sign the sheet. And so QI works. It works not just for us, but it works for the rest of the world as well. Just as a plug, Larry Keft, who is in the picture, with Danielle is, so he is a retired OBGYN. He spends 4 months out of the year, so he spends a month at a time, 4 times a year, working at Tenwek. And so he's going to be here talking about women's health in the developing world. And that's going to be OB Grand Rounds next Wednesday. So for our teams, we're going to be using, we'll use continuity. I think there's an AAP program that we're probably going to use 2 of the continuity programs for. But so I'll be coming around next week. So y'all be thinking about, in continuity, what y'all want to do as far as a project. And the other thing about this is that there's going to be a regional poster symposium, and it's quality improvement, quality and patient safety. First prize is $1,500. Second prize is $1,000. Third prize is $750. So, first prize split between 5 continuity doctors, and maybe an attending. $300 wouldn't be bad for, and it's you can put that in your CV and that kind of thing. But the key is that quality is everybody's responsibility, and that's it. Any questions? All right, thank you.